Sethi for donating their time on a Saturday. I'm sure you will all enjoy the presentation, and thank you very much for attending.
Thank you, Dr. Deneni. I also like to recognize Dr. Mark Seferio, who is our international coordinator-elect, is going to take over this program as of October of this year. And without further ado, Dr. Carl Herman, who is our International Advisory Board Chair, and Professor Muaz Tarabici, our Chair-elect for the International Advisory Board, who will be moderating this session today. I would like to turn the program to them. Thank you very much.
Hello, this is Carl Hermann from Mannheim, Germany. We are in the afternoon here, but we are around the globe, and we are happy to have 1,600 participants from all around the world. And I like to hand over to my chair-elect, which is Muaz Tarabici, the co-founder of the Tarabici Stamberger Institute in Dubai. And Muaz, please start your introduction.
Thank you very much, Carl. It's a pleasure to have all of you with us this afternoon, at least Dubai time. And we have really a terrific lineup of speakers for you discussing an issue that we all faced when doing endoscopic sinus surgery. Sinus surgery is basically done mostly for symptomatic reasons, and it really is a devastating thing to have a significant or major complication when doing a sinus surgery, and that's why we have the experts with us this afternoon. We're going to have three speakers. I think you all read the announcement and aware of the different speakers and their level of expertise. The first speaker I want to introduce is Dr. Dan Bilcetti. He's a very good friend. Everybody knows him, at least on this side of the planet. And Dan, please go ahead and you have the podium. Thank you very much for being with us. Dr. Sethi, you have to unmute your microphone.
Yes, let me share my screen. Well, good morning, good afternoon, good evening to all my friends and colleagues attending this webinar today. And thank you very much for joining us. Greetings from Singapore. And thank you, Dr. Professor Tarabici, Professor Herman, and the entire organizing committee. It's a pleasure to be here, and I'm delighted to share this podium today with Zara Patel and Stacy here. And it's my pleasure to be on this virtual global inaugural lecture of the Global Grand Rounds, and we'll be talking on complications of endoscopic sinus surgery, their avoidance and management. I have no disclosures except some acknowledgements that the case series that I'm going to present, not all the cases are mine. In fact, only just one or two maybe, and most of these are belong from my friends and colleagues from Singapore and abroad, and I want to acknowledge them for giving me the permission to use these cases for this academic event. Thank you so much. Now, no presentation on complications of endoscopic sinus surgery is complete without this quotation from Dr. Mosher. But look at the date here, 1912. In that era, we did not have the endoscope, we did not have the CT scan, we did not have any facilities at all. And these surgeons had to work blindly with poor illumination inside the ethmoids, very near the skull base and very near the orbit. So it is not surprising that they faced complications, and that was one of the easiest way to kill a patient, so they say. Now let's move fast forward by a few decades. Now, our concept of the seminal work that was done by Professor Stamberger and Professor Messer-Klinger has changed the way we treat diseases here. Our understanding of the anatomy has improved. Our understanding of pathophysiology of sinonasal pathology has improved so much. And there also has been a very significant impact on our management of sinonasal pathologies with the imaging technology that is available nowadays. with the CT scan and the MRI scan and the collated information that we have from this imaging technology, we can preoperatively plan our surgery in the minute and execute it in the operating room. The image guidance systems are for safety. We can track our instruments in the ethmoids and avoid the critical structures and save the procedures. We have all the nuts and bolts available. We have high definition cameras. We have powered instrumentation. We have micro debriders. We have drills, you name it. And technology keeps on improving year by year. So, but has this really reduced the incidence of complications? You decide. Now, this is a very interesting article by Professor Dr. Jim Stankiewicz, which basically traces his experience in complications of endoscopic sinus surgery over the past 25 years or so. And what he has noticed that there are certain factors that are responsible for complications of endoscopic surgery. But what I liked was his comments that the use of IGS, image guidance systems, does not necessarily eliminate complications. And complications can occur even in the most experienced hand, and this experience sometimes becomes irrelevant. So that these are, I think, very important comments from his paper. Now, in my 27 years of experience in endoscopic sinus surgery, which started in 1994, I have seen surgery being done for no indications, wrong indication, without preoperative evaluation, without CT scan, without informed consent, without proper documentation, and even proper training and accreditation. And over the years, I've seen and treated some very serious complications resulting from endoscopic sinus surgery. And today, I'm going to present to you a case series of some of these cases that I was involved in their management. And each case will have some lesson to be learned, and I hope by the time I finish the talk, we will have learned a lot of lessons today. So let's go on to the first patient here, and this is, you will note the uncinate process here is very close to the medial orbital wall. This case was being done by my resident. He was using a micro debrider to do this case, and very soon, as soon as he used the debrider, he noticed the orbital fat and stopped immediately. And the orbital fat retracted back. He continued with the surgery, completed the operation, and a timely recognition of the orbital fat averted a major crisis, a major complication which could have occurred. And this patient suffered minimal orbital swelling, which resolved within 24 hours or 48 hours. He was observed for about 24 hours and discharged the following day. Vision normal, all eye movements were normal. Now look at this video very carefully. Same thing, the surgeon is using a micro debrider to remove the uncinate process. And look what happened. Orbital fat prolapse. And he hesitates for a moment and then continues and continues. It took him about 10 seconds to realize that he has breached the lamina capriccia, and this is the orbital fat that was 10 seconds to realize. In 10 seconds, the blade has gone 600 times if it was oscillating at a speed of 6,000 RPM. 600 times, that's enough to do significant damage to the orbit. But fortunately, in this particular case, there was a lot of surgical emphysema, but the medial rectus was spared because of the pad of fat that separates the medial rectus from the medial orbital wall anteriorly. Now take this case. Now this patient, 49-year-old male gentleman, he was an air traffic controller. He underwent surgery for recurrent nasal polyposis. And during the surgery, the surgeon noticed that there was brisk bleeding and the right eye became proposed. And he thought he injured the anterior ethmoidal artery, called in another surgeon to help him. And when the other surgeon came, he noticed that the anterior ethmoidal artery was in fact not bleeding, and that there was a big breach in the lamina capriccia. And by that time, the previous surgeon had managed to stop the bleeding by literally charring the contents of the orbit with the unipolar cautery, as you can see here. But what he did not notice was that the patient had an additional complication, and note the washout sign in the same patient, 2 complications in the same patient, and he had not noticed that. So the CSF leak was immediately repaired with no subsequent consequences. But when we did the post-operative CT scan, the medial rectus has been completely transected. I will not dwell into what the unfortunate cascade of events that ensued after this complication, but enough to say that the airlines could not have him directing to air traffic, and he lost his job. And subsequently, he died of other complications a couple of years later. So a medial rectus injury can be a very devastating complication for a patient, much worse than a CSF leak. Now, this is a case that we do almost every day, bilateral disease. The chronic sinusitis is a routine case, and it was a routine case for the surgeon as well. And they mentioned his note, no surgical event of note, and the surgery went fine. But the patient woke up with the eye completely bruised, the left eye completely bruised and completely blind, no vision at all from the left eye, and was referred to me for further management. So when we did the MRI scan, we saw that the optic nerve had been completely transected. Now, it must have taken the orbital wall to rip apart the medial rectus muscle, go through, identify the optic nerve, and grab it and pull it inside the ethmoid. Significant effort to do that. But that's what happened. And needless to say, her vision never improved. Take this patient, for example. This is another patient. She had been suffering from headaches for the past 7 years. And to relieve those headaches, she had undergone 3 surgeries. She had undergone a septoplasty, turbinoplasty, and endoscopic sinus surgery. And she came to see another surgeon who agreed to operate on her, hoping that by opening up the frontal sinus here, he'll be able to cure her of her headaches. Well, here he is doing the surgery, and using the seeker, he's trying to identify the frontal recess or the frontal sinus, and he thinks he found it. So he probes it further a few times, and is very happy that he's into the frontal sinus. But when he withdraws the probe, you'll see here what happens. Clear washout sign again. So what had happened was that he was not here, but he had perforated the cribriform plate in his attempt to seek the frontal sinus. Fortunately, the defect was very small, as you can see here, barely the size of a pinhead. Barely the size of a pinhead, and it was managed by repaired immediately, and the patient has no consequences and was discharged on the 2nd or the 3rd post-operative day, but her headaches still continue, and they have not been resolved. Now, had the surgeon been using powered instrumentation in that case to identify the frontal recess, perhaps the complication would have been more serious. Now, these 2 scans belong to patients who underwent endoscopic sinus surgery with powered instrumentation. And you can see that the skull base here has been completely removed. And there is a meningoencephalocele. And here, not only there is a skull base defect, but also a fragment of the bone has migrated inside the orbit and is impinging onto the optic nerve. So this is what happened with powered instrumentation. We always behave power instrumentation, but is it the power instrumentation that causes the damage, or is it the hand behind the instrument? I think it's probably the hand behind the instrument. So take this case, for example. Here, the surgeon is using powered instrumentation in a patient with, in a live surgical demonstration with 500 delegates watching the surgery in a meeting. And he is trying to demonstrate safe entry into the sphenoid sinus. And look what happened. He's using power instrumentation. He has no clue where he is, totally disoriented, and he thinks he found the sphenoid sinus. Probes it and keeps on putting his debrider inside, which is oscillating at 6,000 RPM. It takes him 1 minute to realize that he's not in the sphenoid sinus. He's in the skull. He's in the brain. And this is what happened. This is the end result. You see the big hole in the skull base posteriorly. And fortunately for this patient, there was no intraorbital vascular damage. Otherwise, the consequences would have been completely different. In any case, this was repaired and the patient recovered subsequently. This patient here was scheduled for endoscopic septoplasty by a patient, by a surgeon. And the reason was to remove this spur, the septal spur that you see here. So when he woke up after the surgery, the spur was still there, but his skull base was missing. The entire skull base was missing. And you see here, right from here to here, the scalp is missing, and a fragment of the bone has actually gone deep inside and was impinging onto the optic nerve. Must have taken considerable effort to do that. So immediately he was transferred to a facility where there was experienced endoscopic sinus surgeon who did a 3-layer repair for this large scalp-base defect. And I'll show you here. You can see the huge defect there. And that's the brain over there. Fascia being placed, bone cartilage graft, and this is the result for four months post-operatively. He doesn't have the septum anymore, so he doesn't have to worry about these septal spur anymore. And if I tell you that this surgeon who did this surgery was a plastic surgeon, not an ENT surgeon, and the patient was his brother-in-law, I don't think they ever spoke to each other again. This 3-year-old child, sorry, I'm having problems with this. Okay. This 3-year-old child underwent a tonsillectomy, adenodectomy for adenoid hypertrophy and bilateral rhingotomy and grommets. But just look at this maxillary opacity here. Would you do a bilateral endoscopic sinus surgery for him? I would not at the age of 3. But this surgeon did bilateral endoscopic sinus surgery for him. A few months later, he was brought to my clinic by his parents with this CT scan. Oh, there's a mucosal, I thought. But hey, look at the next cut here. There's a large encapsulocele at age 3. Patient underwent surgery with a huge encapsulocele. Anyway, I repaired it, and this is the MRI scan of this patient, and we repaired it, and he's doing fine. This is the CT scan is about a few months after the repair, and he's age 50 now. This was done about 12 years ago. Another patient here, very interesting, and this patient was undergoing endoscopic sinus surgery. During the surgery, the surgeon noticed a lot of bleeding, packed the nose, and sent him to a tertiary care hospital because the surgery was being done in a secondary care hospital. So he packed the nose and visited him into a primary care, in a tertiary center where they did an MRI scan. Note this bubbles here, but these bubbles were actually a large marrow cell pack which has been gone inside the brain here, right here. So you can see this right here. This is a marrow cell pack, big skull-base defect, and a marrow cell pack in the frontal lobe here. And this is the marrow cell pack being removed. And you can see, once it is removed, that there is a large skull-base defect and part of the frontal lobe is missing. So this is another very interesting patient that was referred to me from a neighboring country, and where he had been in the ICU for about more than a month for very life-threatening meningitis. So when he recovered, they sent him to Singapore for further management, and what he had was bilateral encapsuloceles. 4 years prior to this episode of meningitis, he had undergone endoscopic sinus surgery. And when he came here, we did an MRI scan for him, and true enough, there is bilateral encapsulocele. But there was a very odd lesion here, which we could not identify what it was. Nobody would put a finger at what it could be, neither a radiologist nor us. So finally, when we explored him and did a surgery on him, we found that this was a piece of gauze that was left behind 8 years ago by the surgeon who had operated for him. So this was actually a piece of gauze that was forgotten and never removed. Most of us have fear of the anterior ethmoidal artery, and rightly so, because if the anterior ethmoidal artery is transected, it will retract inside the orbit, and even 5 milliliters of bleeding in the orbit can give you an orbital hematoma significant enough to threaten the vision. So we are rightfully scared of it. But that happens when there is complete transection of the artery. But most of the time, if the artery is just lacerated, partially lacerated, then it can be easily controlled by just applying bipolar onto the artery. Here you see a small defect there, just a suction, put in a small pack, use a bipolar, and you'll be able to handle this situation as we did in this particular case. This is a very old clip. This is one of my own cases that was being done by a resident. and you can see we've controlled it with bipolar. In fact, even the sphenopalatine artery, infraorbital artery can be controlled with bipolar, but you need to have bipolar for all situations. No one single bipolar is ideal. You need to have different kind of bipolars to navigate them into the different nicks and corners of the nasal cavity. But the infratemporal fossa is a different ballgame altogether. You have to be very familiar with the vascular anatomy of the infratemporal fossa and the entire anatomy of the infratemporal fossa, in fact. And the juvenile angiofibroma, as we call it, is one of the commonest tumors that occurs in the infratemporal fossa, and they can bleed. Despite pre-operative embolization, they can still bleed. And here is this patient who has been embolized before the surgery, and but look at that, torrential bleeding, and bleeding can be frightening. And that is where you wish you had another extra pair of hands, and that could help. And here there was profuse bleeding. As you can see here, this was even post-embolization, and extra pair of hands really helped, and because the surgeon was then able to clip the artery with the exposure. Was able to clip the artery, there you can see here, and the situation was resolved. Now the sphenoid sinus, I believe, is the most vulnerable sinus of all the sinus, of all the paranasal sinus. And why so? Because there are so many significant, important structures in the sphenoid sinus. You have the cavernous sinus, you have the internal carotid artery, and you have the optic nerves, and all these are vulnerable to when there is pathology in the sphenoid sinus. Now, in a very well aerated sphenoid sinus, you can see the optic nerve, dehiscent optic nerve, and it looks beautiful. But what makes you think that the optic nerve is not dehiscent in an opacified sphenoid sinus such as this? It may be dehiscent here also. Now, always be wary of opacity inside the sphenoid sinus. This very benign-looking retention cyst that you see here is actually an aneurysm of the internal carotid artery. And this opacification that you see in the lateral recess is not just a polyp or a fungal disease or even an encephalocele. You can see the skull base here is detached. But what it turned out to be was a giant aneurysm of the internal carotid artery that had come into the sphenoid sinus. So we have to be very, very, and pre-operative planning is extremely important where the sphenoid sinus is concerned. So here is, I have seen some very brave surgeons, honestly, in that my 27 years, they're very brave. They can peel the tumor off the internal carotid artery, seen them off. But this one tops the totem list. And here he is, totem pole. And here he is using a true cutting forceps on the carotid artery, true cutting forceps. And watch what happens. Boom. There is suddenly bleeding everywhere. And anyway, this was managed, and I'm sure later on Zara will be talking on the management of intracarotid artery injury. So I'm not going to go into the management part of it, except that this should never happen. And if it does happen, you should have a plan for it. And here we always use Doppler to track the internal carotid artery so that we can avoid it. And here is this surgeon who used the Doppler. He's doing this surgery for a recurrent pituitary adenoma, and he's doing used a Doppler. You can see here he's using a Doppler. He tracks the internal carotid artery, and then uses a knife to puncture the internal carotid artery. Look at that, and there you go. He uses a knife just exactly where he found the artery. He punctures that. Again, I will not go into the management of this, and all these complications that I showed you could have been prevented. Now, here is another patient, and I think I'll be just one or two cases more. And this patient actually underwent endoscopic sphenoidotomy for a lesion in the sphenoid sinus. Okay. And the surgeon encountered profuse bleeding, packed the nose, and whisked her off to Singapore. She was from a neighboring country. And when she came here, she was blind by the left eye. She couldn't see. She had third nerve palsy. She had sixth nerve palsy, and the pupil was dilated and fixed. Did an angiogram for her, and there was a large aneurysm involving the paracellular internal carotid artery, just proximal to the ophthalmic artery, and there was a large shunt as well. You can see the superior ophthalmic vein is dilated here. So we had a very experienced international radiologist who attempted a covered stent. For 8 hours, he couldn't put the stent in, and during the procedure, the patient had a massive stroke, and it took her, and she never recovered from the stroke, but as soon as her condition improved, the neurosurgeon did a common carotid and MCA bypass using the saphenous vein graft. But the bypass was successful and the patient was discharged about a month later, but she died subsequently of septicemia in her country. That's what I was told. So when you look at the CT scan of this patient, I was amazed to see that there was hardly any pathology in the sphenoid sinus. There was nothing in the sphenoid sinus. In fact, there's just a little bit of edema. There was nothing in the sphenoid sinus, and how this and the patient lost her life when there was no absolute indication for the surgeon. Now, this is a very interesting case, and here you'll see that there is the lateral recess is completely opacified, and there is a large skull-based defect here. So obviously, from the CT scan, it's obvious that this is a encephalocele. So a transpterygoid approach to repair the defect was used in this case, and here you see. And the usual measure, the surgeon applied bipolar to the encephalocele, but because the encephalocele was very large, he could not reduce it back intracranially, so he decided to truncate it. And what happened when he truncated it at the defect, there was profuse bleeding. You can see that. Profuse bleeding from that particular area. Tried his best to stop the bleeding. It took about 45 minutes, but he finally managed to stop the bleeding, did the repair, and the patient was sent back to the ward. 2 hours later, the patient developed a stroke. And an emergency CT scan was done, and it showed a massive intracranial hemorrhage, as you can see here. So emergency craniotomy and was done by the neurosurgeon, and the patient spent almost about 6 weeks in the hospital, and subsequently went home with some weakness of the right side. So again, this was what was interesting about this case, that when we looked at the MRI scan, neither the radiologist nor the surgeon had seen this artery that was actually prolapsing inside the encephalocele. And you can see it retrospectively, this artery here. You see that this is the encephalocele. And so when you truncated the encephalocele here, it resulted in bleeding. He managed to stop the bleeding into the sinus, but not the bleeding inside the brain that continued. So this was really again, this could have been prevented if the surgeon has reviewed carefully the MRI scan, or the radiologist also had reported that there was a blood vessel inside the encephalocele. So I believe that there are, in this case series, there were several lessons to be learned, and I hope we go back home with the message that major complications can occur, but they can also be avoided with careful planning using the technology that we have available. Proper training and accreditation is essential, and you must always know your anatomy, plan accordingly. Surgical expertise is very, very essential. Although complications, yes, they can happen in the most experienced hands as well. And be careful when you use power instrumentation. So thank you very much for your attention.
Thank you very much, Dan. Some of these videos are very painful to watch, I have to tell you. Thank you. And next speaker, we're going to have the questions at the end of the session. We're going to have a bit of a discussion at the end. Next speaker is Stacy Gray from the Mass Eye and Ear Infirmary. She is the director of the Sinus Center. So Stacy, please go ahead. You have the podium. You need to unmute your...
Thank you. I'm going to go ahead and just start sharing my screen. Let's see, it's not giving me the option. Let's see.
Are you able to?
No, not yet. Hold on 1 second. Let me just try that again. Now it is. Sorry about that. Are you able to see my screen?
Absolutely.
Okay, great. So first of all, just thank you so much for giving us the opportunity to be part of this incredibly esteemed panel and wonderful initiative from the Academy. It's really nice to have a chance to be here today. What I'd like to do is echo a lot of what Dr. Sethi just mentioned, but thinking about ways to preemptively avoid and then also manage complications that happen during endoscopic sinus surgery. This is a version of a course that Dr. Patel and I give at the Academy meeting every year, and something we've been doing for the last 5 years and really enjoy doing. So it's wonderful to do this as a part of this course as well. I don't have any disclosures for this talk. All of the cases that we just saw, I also really felt in the pit of my stomach as we were just watching Dr. Sethi present. And I think we all recognize that there are some really drastic and immediate complications that we should hopefully never encounter in our practice. And a lot of the principles that he mentioned, which really include excellent surgical planning, can hopefully decrease the chance of a severe orbital injury like this patient, or a severe bleeding complication, so that this never happens. On the other hand, there are many complications that occur that are quite much less catastrophic, but significantly impact our patients, like this patient who has significant anosmia, scarring of the frontal recess, and significant frontal sinus disease postoperatively due to overaggressive surgery. And these are complications that are often underreported and not talked about as much, and really can also be avoided with good surgical planning and good surgical technique. And so really what we're talking about is the fact that avoiding complications, rather severe and extreme, or something as minor as synechia, will help to improve our patient outcomes. And that really starts from the very first time that we see our patients in clinic, assessing them all the way through the operating room, as well as their postoperative management. So I'm going to cover preoperative assessment, evaluation, and surgical planning. And then Dr. Patel will talk about optimizing surgical techniques in the operating room and postoperative management. So it really starts with seeing our patients in clinic. And we have several tools that help us to make a plan and think about what we might encounter in the operating room. That includes endoscopic examination and our knowledge of imaging studies, which are some of the main things that I'm going to talk about when we are thinking about preoperative assessment. This is a patient that was sent to me with a diagnosis of a maxillary sinus tumor. And so obviously the patient had significant concern about what this might mean. When I saw the scan, obviously you can see the significant erosion of the medial maxillary wall. The endoscopic examination of the middle meatus really was fairly unrevealing, with bulging of the medial maxillary wall. But in the inferior meatus, there is obvious fungal debris. And so correlating the scan with the endoscopy in the preoperative setting really allowed me to discuss with this patient that this was likely to be a fungal ball rather than a malignancy. My surgical planning was a little bit different, and my discussion with the patient was similarly different as well. Similarly, this is a patient who was referred to me for a frontal sinus mucocele with significant headaches. And at the time that I saw her, paying attention with an endoscopic examination in the middle meatus, there was a small area just in the superior middle meatus that did not look typical for sort of standard mucocele abnormality. But I wasn't really able to see things very clearly. And in this case, I decided to do an MRI prior to the operating room. And you can see there's a fairly large tumor that's actually centered in the frontal sinus that has caused a secondary mucocele to form. This ended up being an inverted papilloma, but my ability to identify that before going to the operating room, again, discuss my surgical planning and the possibility that this would involve potentially a second surgery with the patient even before going to the operating room, was extremely helpful as far as counseling the patient and her understanding of what surgery would entail. When you're seeing patients preoperatively, I think there are several things that really can be helpful to try to decrease the risk of an intraoperative complication and also improve postoperative results. So I think one of the things, especially as we're in the midst of COVID right now, and we're all sort of approaching the way that we're seeing patients in clinic and planning surgery has sort of changed over the last year. Reassessment of the patient's disease status close to the time of surgery, I think, is really important. And that might mean obtaining an updated sinus CAT scan if you have not seen them for many months, or they haven't had an imaging and study in many months, especially if you're planning to use image guidance during the surgery. Assessing for comorbidities, certainly in my practice, is something that's extremely helpful, whether it's a cystic fibrosis patient who has had a lung transplant and we need to make sure that their pulmonary status is optimized, to something as simple as a patient who is on anticoagulation for atrial fibrillation. If you're unaware of that, you then are in a situation the morning of the surgery where you might have to cancel the case if you haven't addressed this, or accept the possibility that you're going to have a higher risk of bleeding during surgery. So really reviewing the patients before the day of the surgery, closer to the time that you're seeing them in the office, really can be helpful for this. In addition, preoperative treatment with things like antibiotics or steroids might be helpful to improve, again, the possibility for doing a more complete and more thorough surgery at the time of the surgery. There are some factors that can lead to poor outcomes that we can predict preoperatively. One is really patient perception. So in this patient with severe recurrent polyposis, if their main goal for a revision surgery is improving their sense of smell, and you are thinking that you're really just going to improve their nasal breathing, the mismatch between the patient expectation and what you think you're going to accomplish from surgery can certainly lead to disappointed patients, which is not a complication, but certainly something that we need to keep in mind. Really explaining the goals of surgery and making sure patients have realistic expectations is extremely important. That really happens at the time that you're doing your informed consent with patients. The other is distorted anatomy, and this can occur because of the disease process itself, whether it's significant polyposis, patients who've had prior surgery and significant scarring, or just anatomic variations. The other issue is the inability to access certain areas if you have not done your surgical planning properly. And so sometimes that means a severe septal deviation might impact your ability to do a complete sinus surgery, or you might need to consider an adjunctive external procedure for access as well. Those are all things that can often be predicted preoperatively rather than having to be faced with that in the setting of the operating room. The idea of a checklist, I think, is something we're all comfortable with in the operating room, and it should be also something that we use when we're looking and reviewing our images prior to surgery, because really this provides the roadmap for safe and complete endoscopic sinus surgery. So I'd like to just very briefly review some potential anatomic abnormalities that can lead to increased complications if not recognized, or certain structures that really you want to pay close attention to when you're doing your preoperative review. The maxillary sinus or maxillary antrostomy is often thought to be the most simple component of our surgery, when in actuality, I think it's extremely complex and under-recognized as the potential way that patients can have significant complications, especially things as simple as maxillary sinus recirculation or scarring of the maxillary sinus. So really looking at the space of the uncinate process and how it's impacted by things like a Haller cell can really help us determine that three-dimensional anatomy before we're even in the operating room. In this case, that Haller cell is attached to the infraorbital nerve. And if you're planning to dissect the inferior aspect of that Haller cell, it's important to recognize that how you're doing that might actually have a negative impact on the infraorbital nerve. So it needs to really be closely addressed when you're in the operating room. Similarly, atelectasis of the uncinate process puts the orbit at risk. In this case, it's quite obvious because you have silent sinus syndrome and the orbital floor has really been pulled into the maxillary sinus because of negative pressure. In addition, the bone around the orbit is significantly thinned. This really puts that orbit at risk if it is not adequately addressed prior to the surgery. But uncinate atelectasis happens quite frequently without actually having silent sinus syndrome. And looking at that beforehand and understanding how close you are to the orbit when you're doing the maxillary antrostomy is extremely important to avoid an orbital injury. We often think about injury to the nasolacrimal system as a component of enlarging the antrostomy anteriorly. That, I think, is actually fairly unusual because the bone in that region is quite thick. Where it's less sort of talked about and where it's an area where often it is potentially risk is much higher. So not when you're doing maxillary antrostomy, but actually if you're dissecting in the Auger-Nazi region. And that's because the nasolacrimal system is often dehiscent in this area. This is something that you can easily identify with pressure just at the medial canthus when you're doing dissection in this region. And it's important to recognize the difference between dehiscence of the nasolacrimal system and a lamina dehiscence, which also both can show movement in the operating room. But this is an area that can easily be injured, especially during a frontal recess dissection if it's not identified preoperatively. We often talk about the integrity of the skull base and the shape, Caros typing of the skull base. I think what's more important to recognize is asymmetry. So in this situation where you have a very box-like shape to the ethmoid on one side and you have a very sloped shape to the ethmoid roof on the other, your natural tendency when you're doing surgery bilaterally is to think that the sides will be similar. And so in this situation, you might think that there's actually an extra layer of an ethmoid cell that still needs dissection if you haven't recognized the asymmetry between the two sides and inadvertently cause a skull base defect. The integrity of the lamina is obviously very important to recognize, and there are many cases where patients are unaware that they've had an orbital fracture in the past. In this situation, it's very easy to understand and see that the orbital contents have actually transgressed into the ethmoid cavity. If this was a diseased scan, it would obviously be much more difficult to recognize. And so surgical planning about how you're going to handle that, if there are orbital contents in the ethmoid cavity and you need to do a dissection there, is very important. The position of the anterior ethmoid artery is something that we've already talked about in orbital hematoma, potentially developing. This second situation where you have significant aeration of the supraorbital complex really puts this anterior ethmoid artery at risk. So when you're thinking about doing an ethmoid dissection, it's important to recognize that beforehand, make sure you're comfortable dissecting in that region, and also really looking for the actual placement of the anterior ethmoid artery to avoid injury. We often don't think about the posterior ethmoid artery being at risk. However, in some patients, again, with significant pneumatization of cells above the orbit, you can actually have a situation where both the posterior and anterior ethmoid artery are in the pathway for potential surgical dissection when doing an ethmoidectomy. And again, these are issues that can all be seen very easily in the preoperative scan. I think that looking at the position of the actual sphenoid ostium is extremely important. In this situation, the ostium will be very readily apparent, looking between the superior turbinate and the septum, and very easy to identify and dissect. In this situation, the sloped shape pathway towards the sphenoid ostium, because of the rostrum and the nasal septum, means that you will have to dissect more laterally. Not a problem at all, but something that you can easily look at right before doing the dissection and make sure that you really can identify the ostium before doing a sphenoidotomy, which significantly decreases the risk of having a complication of entering into the sphenoid region in the wrong area. We all know that the optic nerve and carotid artery can be dehiscent within the sphenoid sinus. This is a patient of mine who unfortunately came to me after having developed a pseudoaneurysm because of injury to this carotid artery in the sphenoid sinus. The most important thing is that if there is a risk of sphenoid injury, the determination about whether or not a sphenoid dissection should even be performed is something that surgeons should really think about. In a case like this, there was not significant sphenoid sinus disease, and yet the decision was made to dissect that really complicated sphenoid, and unfortunately the patient ended up with an injury. So when you realize that there is a structure at risk, it should really make you think about whether or not you need to even think about doing a sphenoidotomy in this case. The frontal sinus is obviously almost a completely different lecture. The outflow tract itself can really put patients at risk, mainly for potential scarring after the surgery. And I think it's important to look at that and look at the complexity to really understand your risk, potential risk of scarring, and how much extent of frontal sinus surgery will be necessary even before you're in the operating room. The integrity of the posterior table is also obviously important to recognize as well, especially in situations like this where there's a mucosal cavity. Distorted anatomy can happen from prior surgery, and in this situation, for instance, there's a small meningoencephalocele that was initially thought to just be recurrent polyposis in the olfactory cleft, so obviously very important to recognize prior to revision surgery. And in this situation, the patient with really bad recurrent nasal polyposis from prior surgery has scarring of the middle turbinate laterally, as well as this dehiscence in in the orbit. In this situation, this was extremely scarred in this region. And so instead of trying to dissect the normal way into the middle meatus between the middle turbinate and the orbit, in order to do a frontal recess dissection here, going directly to almost a draft 2B or a draft 3 procedure is going to make sure that you don't put this orbit at risk trying to dissect in this space. And again, all things that can be easily identified on preoperative close inspection of the CT scan. And then the fact that the anatomy might be distorted by the disease process itself. So in this situation, clearly the sphenoid sinus will have to be surgically opened and managed, as opposed to the other case where there was not significant sphenoid disease. This patient also has dehiscence over the carotid arteries, and this is a fungal ball. So in this situation, having an upfront discussion with patients about the potential risk is extremely important. Certainly more extensive imaging studies like an MRI or even angiogram might be considered if there's actually a concern that this could be an aneurysm of the carotid artery. And again, all of these are issues that can easily be thought about prior to the surgical actually being in the operating room. And then the last thing as far as preoperative planning is thinking about the extent of surgery. So thinking about this before you're even in the operating room and tailoring the extent of surgery, not only to the disease process itself, but also the patient's symptoms to make sure that you do a complete surgery without doing more surgery than is necessary. And then also thinking whether or not adjunct procedures might be necessary. And that's something as simple as a septoplasty, which can help not only your surgical access, but also access for postoperative debridements. And also in this case, obviously in an extensive frontal sinus osteoma, this might not be something that can be addressed with an endoscopic approach alone. And so thinking about whether an external procedure or consultants with other specialties like neurosurgery or ophthalmology might be something to consider, and should be something you're thinking about way before you're ever in the actual operating room. And so with that, I'm going to go ahead and finish my portion of the talk and switch so that Dr. Patel can now take over.
Thank you very much, Stacy. I enjoyed the talk. If you have any, please start working on your questions, because after Zara speaks, we're going to have a panel discussion. So next speaker is Zara Patel. She is the Director of Rhinology and Sinus Surgery at Stanford. Thank you for joining us, Zara. You have the podium.
Wonderful. Let me just start sharing my screen with all of you now. Oh, let me go back to this and just go back to the beginning. Okay, great. Give me a second. Okay, that should be good. Can you all see my screen now?
Sure.
Okay, wonderful. Well, thank you to the Academy and to the committee for thinking of us to start off on this inaugural session. Honored to be here and really happy to see all of our participants and audience members. And like Dr. Gray mentioned, we give this course together every year at Academy for several years now. And it's such an honor to have Dr. Sethi present his case presentations before we started talking about this, because they're so compelling. It really makes you nauseous to see these really terrible complications occurring as you watch. But I think it is a really important topic. And now that Dr. Gray has told everyone how to, in every possible way, think about how to avoid these before you get to the operating room, I'm going to go ahead and talk about once you are in the operating room and after. These are my disclosures, none are relevant. So once we're there, before you actually start the surgery, it's the same thing as everything Dr. Gray just mentioned. You really want to think about how to prevent anything from occurring before you even touch the patient. So having an endoscopic sinus surgery checklist is really important. We have checklists for all sorts of things now in what we do. We have a timeout type of procedure in general for surgeries around the world. We have checklists for all sorts of business applications. And Tim Smith and Zach Soler actually formulated a sinus surgery specific checklist that you can do for this particular type of operation. So making sure that the correct imaging is displayed in the room. Surprisingly, sometimes you walk in, some trainee has put imaging up on the screen, and it's really up to you to make sure that it's the right patient. It's the one that you're about to operate on, because certainly human error is a big part of everything that we do. And every time that you go through things, everyone checking each other's job is making everyone safer. Reviewing the anatomy on that scan before you start so that it's fresh in your mind, so that you formulate that three-dimensional view of what they're going to look like before you even get in there. And then making sure that you have all of the equipment that you need in the room in order to manage directly any particular complication that could arise in a rapid fashion so that it does not worsen over time. Having a plan for hemostasis is really important, which I'll go through a little bit, but bleeding is one of the things that distorts our view most in this type of surgery. So if you're not going through the entire time and making sure that you have a really nice, meticulous, bloodless field, you very easily can get into complications without realizing it. And then labeling of medications. One of the things that we use to control bleeding is topical epinephrine, for example, and making sure that that's labeled and no one ever hands that to you in a syringe to actually inject into a patient, because you'd cause a massive MI if you injected something like that. These types of things are really important to think of before you ever start. So speaking of controlling bleeding, doing simple things like raising the head of the bed. We've shown that 30 degrees of head elevation is enough to decrease the amount of blood in the field, but it still allows for blood flow to the cerebral cavity. So you want to make sure that you don't have the patient so far up that you're decreasing blood flow and causing things like a possible TIA or stroke just because you have the head in a particular elevation and the map very low. So keeping things like that in mind. The type of anesthesia that is used can be really helpful. TIVA stands for total intravenous anesthesia, things like remifentanil. These types of medications are very good at controlling pain, keeping a patient under anesthetic, but also not dilating all the blood vessels like a general anesthetic would, the inhalational types of general anesthetic would. And so using particular types of anesthesia can be very helpful in decreasing blood loss during the operation. And then, like I mentioned, vasoconstrictive agents, we routinely use topical epinephrine now in every single case. We often don't even need to inject when you're using topical epinephrine. We just published data on this showing that there really was not a significant difference in bleeding during an operation when using topical epinephrine versus injecting first and then using topical epinephrine. And the most important thing is to make sure that this is safe. So the way that we make sure that it's safe is by using fluorescein, just a little strip, the type that you put in the eye that ophthalmologists use to dye when they're looking in the eye. If you just put that in the actual epinephrine and then place the pledgets inside that, it becomes this bright, greenish yellow. And that will prevent anyone from handing that to you in a syringe. And even if they did, when you looked at it, you would not inject it. So there's ways of making these safe. Once you start the surgery, you really want to already have your plan in place. You don't want to be kind of guessing as you go through or seeing how it goes and then making your decisions. Certainly thinking on the fly is part of being a surgeon, but having a correct plan in place allows you to be much more efficient and much more skillful in the way in which you approach inflammation or tumor or anything like that. Following the same steps each time is also really important. Even when a patient has had surgery in the past, even when they are missing particular landmarks, if you go through the same steps every single time, you're much more likely to be able to find landmarks, even when many other landmarks are missing, find particular borders of your surgery, and therefore move forward in a safe fashion. For example, even if someone has already done a maxillary antrostomy in the past, just looking at it and making sure before you move on to whatever the other pathology is that you're there to address, and making sure that it is the type of maxillary antrostomy that you would want to make and that you're not missing anything. You're not going to leave some recirculation in place that you could have addressed at the time of surgery. Making sure you are complete and thorough in your dissection. There are the catastrophic complications like the ones Dr. Sethi was showing us, but then there are also more minor complications when people need revision surgery, they have scarring, they have issues that are not resolved. Those are complications you also want to avoid when doing surgery. And so being careful and meticulous with your dissection really helps with all of that. So like I mentioned, even in these cases where traditional landmarks are removed or obscured, you really want to follow the usual steps. This is an example of that recirculation that we see so often when someone has had a surgery elsewhere and they come in and they actually have not had their maxillary antrostomy connected with the true ostium. You'll get, your sinus doesn't care where another hole has been placed. It's always going to direct the mucus towards its natural opening. And so just taking down a little last bit of that unsnip process, you realize allows you to see this. And even though when you first looked into the sinus cavity, it really looked like the sinus had already been opened, you didn't have anything else to do in this area, just taking that moment to start where you would normally start and make sure that it's as complete and thorough a job as you would want allows you to, bring this forward for the patient and not have them have that issue in the future. So what happens when you do have one of these worse complications, something like, damage to the orbit or a CSF leak or, heaven forbid, a really big bleed? So when things are not going according to plan, you really want to just stop. You want to take a breath. You want to check in with yourself, lower your blood pressure, allow yourself to consider what's going on with the situation before you start directing anyone else what to do. You are in control of your operating room as the surgeon, and everyone will be looking to you to know how to act. So just calm yourself. Review the goals of your surgery. If you can continue, repair whatever has happened and continue with the surgery and finish with the goals in mind, wonderful, continue to do that. But you definitely don't want to continue if you think that it's possible you're going to make things worse. If you are not sure how to deal with whatever has happened, surgery can always be staged. You can just stop. You can always make sure that, you're not going to make things worse by moving forward. Recognizing the issue, exactly what has happened. If suddenly the field is filling with blood, don't just continue to operate through the blood because you want to get to the end and you want to be efficient with your time that day. Stop and try to recognize the issue. Where is the blood coming from? Really direct your attention to what the problem may be. Like I said, repair if possible. If you know how to repair it, wonderful, you're all set. If you don't, that's okay. It's not the end of the world. Call your colleague. If you have a colleague at your own institution that you trust and is more senior or more experienced or simply just has training in that particular type of repair, call them. No one will ever hold it against you for calling for help. Also, if you don't have anyone else at your institution or your particular surgical center, you can always call someone outside. Call one of us, call me or Dr. Gray or Dr. Sethi, and figure out what it is that is the right next step. No one in our position will ever fault anyone for calling us. And we are always so happy to have someone ask us what to do, because then you can prevent things from getting worse. So really always feel like you have the ability to call. That is what our global, national and international communities are for, so that we can reach out to each other when we're in need, and we're all here for you. So if you are there and trying to figure out what to do, these are things that you can do. So for control of bleeding, warm water or saline irrigation is actually quite helpful in just decreasing overall bleeding from surfaces. Like Dr. Sethi mentioned, always have your bipolar and suction cautery available. It's true that there is not one particular bipolar that can access all parts of the skull base and sinus cavity. So having a few different options available, if you have the ability in your OR, is very helpful for accessing all these different areas that we may have problems at. Knowing how to perform ligation of the sphenopalatine and anterior ethmoid artery is key. So if you have not done that since training, or you just haven't ever encountered this, going into a lab, doing cadaver dissection, really identifying where these arteries are and how to access both of them endoscopically is really key in being able to address any problem that you have with them if you ever get into that problem in a live surgery. And then, of course, having all of these topical hemostatic agents available for you in the room and available to be opened quite rapidly if needed. So here's just an example of a case where a patient had a surgery at an outside institution and they began bleeding. The surgeon felt like they ligated or cauterized the sphenopalatine artery, but the patient continued to bleed. They couldn't figure out what was going on, so eventually they just packed and sent to me for me to help. You can see here that what they had actually cauterized was an inferior branch of the saphenopalatine artery. This is kind of an old video, and I don't necessarily use arterial clips anymore. I might just cauterize or bipolar. But, you know, knowing that there are multiple branches of the saphenopalatine artery, and knowing that you have to really look for all of them to make sure that you have, you know, controlled all possible sources of bleeding in that area is really key. You can have multiple branches bleeding and then just have one branch spasm closed while the other branch continues to bleed. So just because you've controlled bleeding for a moment doesn't mean that you might not have some bleeding after the fact. So really identifying all those branches. The anterior ethmoid artery, I think, you know, most of us as sinus surgeons or ENT surgeons during our training have been taught how to access the anterior ethmoid artery through an external approach, making a little incision and tunneling in that way, which is fine. If that's the way that you know how to control the anterior ethmoid artery, that is perfectly reasonable way of accessing it. However, I would encourage all of you, you know, now that we have such better endoscopic technique, instrumentation that really allows us to access the anterior ethmoid artery directly endoscopically, this is often the best way of accessing it if you need to, you know, for any type of bleeding, either intermittent bleeding on an outpatient or something that happens in the surgery itself. Just really being able to skeletonize, remove the bone around the entire artery, and then taking that artery, really making sure that you leave room for it so that it doesn't, if you're in the middle of cauterizing it and you divide before the cautery is complete, that you don't have the artery retract into the orbit, because you really want to avoid that dreaded orbital hematoma complication. So carotid injury, you know, this is thankfully pretty rare when we're doing sinus surgery, a little bit more common, but also thankfully rare when we're doing endoscopic skull-base surgery. And there are multiple options for dealing with this. So, you know, I would say the very first thing is simply just controlling the bleeding. You can lose a lot of blood very quickly out of this artery. So making sure that you have packing available, place direct pressure with just a pledget or whatever you have available to you, while, you know, directing the flow of blood away from the endoscope. Doing this in a four-handed approach is the easiest way of doing this. And when this happens in skull-base surgery, the person holding the camera can really use a suction to direct blood flow away from the camera while the other surgeon places pressure. And then you can decide what's the best way of repairing the artery itself. But really making sure that you apply enough pressure to control the bleeding, but not so much pressure that you completely decrease blood flow to the brain. It's a gentle but firm pressure. You want the artery to still be supplying blood flow while you're holding off blood flow into the sinus cavity. So the amount of pressure is really important. Crushed muscle has been shown to actually be the most effective way of trying to decrease bleeding directly during the surgery itself. So having, you know, either packing it off and then yourself going and harvesting some muscle. You can harvest buccal muscle or temporal muscle, any of those muscles, and then crushing it to release those good enzymes that really allow for the blood clotting to happen, and then placing that patch directly on the injury. You can do this by slowly removing the pledget that you have in place, placing the muscle, and then again directly applying that pledget and packing into position. That is the best way of directly controlling. Sometimes if you can see just a very small injury that a U-clip could control, that's another option for you to directly apply endoscopically, but that's much more rare that you're able to do that. Having vascular injury training, if you're going to be operating in and around the carotid artery routinely, I think is key to really knowing how to handle this in a very methodical, effective way when you're in the area. For leaks, I would say this is probably one of, other than bleeding, one of the more common things that people get into when they're doing sinus surgery as a complication. Identifying and exposing the entire area is really key. You don't want to just patch part of the leak because you didn't expose all of the area around it and you missed some other part of the skull base that had a crack and you continue leaking out of there. So really, making sure that you identify the entire area, avoid injury to surrounding structures while you're working in the region, and then making sure that you can really complete the sinus surgery around this before you repair it so that you don't end up having some blocked frontal sinus drainage pathway that you put a repair over. Exposing the entire bony defect so that when you do put a repair, that it really has the ability to heal in place well, removing surrounding mucosa so you don't have mucosal formation, and then really repairing based on size. A mucosal overlay graft is often all you need to repair a very small defect. I would say, 5 millimeters to a centimeter is really a small mucosal overlay. If anything is bigger than that or higher flow than that, then we start thinking about nasoseptal flaps and things like that. So here's an example. This is actually just a very small tumor that is at the very posterior aspect of the septum where it meets the ethmoid skull base. And you can see we're removing that. And based on imaging, we did expect to get a little leak, but in this area, this is an area where you very easily could perhaps get a leak when you're doing sinus surgery. You can see there's some bone, but when you press against it, you can see that washout sign and see the leak of fluid. And so you can see this is a very small defect. So just harvesting some mucosa from the nasal floor, a free mucosal graft, using your needlepoint bovie and just directly bending it to get that area. This is a very nice, pliable, flexible piece of tissue that you can see you can place into position, and it really conforms to whatever the skull base is in that area, and it creates a really nice watertight seal. This is just a little tissue glue. And then a little bit of absorbable packing as a bolster to keep that in position and in place. This is really all you need for small defects. You don't necessarily need to go somewhere else and harvest fat from some other part of the body. You get a second surgical site in those cases. So really just a little mucosal graft. This is a video that I actually made for the American Rhinologic Society and is on their website, but this is after a pituitary surgery, but this is just to show you if you were going to, if you're going to have a larger defect that perhaps you had created inadvertently during sinus surgery and you wanted to harvest a nasoseptal flap, this is how you do it. You can, again, bend that needlepoint bovie. I'm using it on 15. By bending it, don't skive so that you get a really nice direct cut. And then as you bring it forward along the floor, here you are. And then I come up and ride right above the vessels down by the decussators. When you make your superior cut, you want to make sure that it's not so high that you're going to get another leak there, not so high that you're going to damage olfactory fibers, but just inferior to the olfactory epithelium. And then raising a nasoseptal flap is just like doing a septoplasty. As soon as you get into the right plane at the very front, the entire rest of that mucosa will zip off of the cartilage very smoothly and easily. And you can see this is a very robust pedicled flap, so it has its own blood supply. You can use this in any high flow leak setting, any larger defect that the simple mucosal graft is not going to be enough. So that's just an example for that. So orbital injury, we certainly saw plenty of examples in both Dr. Gray and Dr. Sethi's presentations. And this is really a dreaded complication. As both of them mentioned, this can really be devastating for someone's quality of life moving forward. So if you feel like you have gotten any issue like this, first of all, again, take a moment, take a breath, start communicating with your operative team. Call for ophthalmology immediately so they can come and help you do a consult. Even if you know all the steps of checking intraocular pressure yourself and managing how to release that pressure, having that other specializing consulting team is really not just for medical legal reasons, but also just for patient confidence. Knowing that you did everything possible to make sure that they were getting the best possible care after a complication occurred goes a long way in making sure that they feel that you did a good job, even if you got a complication. And that's something else, one of the questions that came up in the Q&A while Dr. Sethi and Dr. Gray were speaking, someone asked, how do you tell a patient? Well, we can discuss that at the end, but really being upfront and honest and really telling the patient that you did every single thing possible once the complication occurred to manage that complication goes a long way in comforting the patient, comforting the family, and giving them the confidence that you still are the person that they want to continue managing this issue. So you have to check the pressure, check the afferent pupillary defect. You have to consider canthotomy and cantholysis if you do think that you've had a hematoma swelling into the eye. So if people haven't done this, again, I encourage you to go into a cadaver dissection lab and practice this so that you know how to do it. you basically just do a direct lateral cut from the lateral canthus, and then turn your scissor directly perpendicular down onto the orbital rim, that bony rim, and cut again. That final cut is really what's going to release the canthal tendon and really allow for the most release of pressure. Just doing the cut laterally on its own is not going to be enough for you. So, avoiding catastrophes is really important, but long-term complications, preventing inadequate surgery or over-aggressive surgery is really important too. So let's talk a little bit about post-operatively when we think about these things. The most common thing we see as a complication after surgery is synechia or scarring. Having this middle turbinate scar to the lateral wall and close off all of the sinuses that you just took all that time to open is really unfortunate to see. So there are many different techniques of trying to avoid this. I'm just going to demonstrate to you here what I do in the operating room. I just use a simple natural gut absorbable suture, and I just make a small little lasso stitch around these middle turbinates to draw them to the septum. This is actually much nicer than Bolgerization, which Bolger actually himself does not even do anymore, because you can get scarring from that to the septum, and that can decrease olfaction, that can lead to loss of smell and taste. And so really just bringing the middle turbinates medially during that immediate healing period allows the patient to heal without any scarring, really. And then suture dissolves and the middle turbinate just hangs in its natural position. You can see that I'm going around the middle turbinate and not actually going through the turbinate itself, because that's just a much easier stitch to place. The septum becomes very thin. Sometimes you don't even have much bone in the back there. And you can see this video that I'm showing you, I purposely really did not edit much at all. It just took about 30 seconds for me to place that suture. And that's going to allow the patient to heal really nicely without any scarring. So that's one option. There's many different options of how you can try to prevent scarring. There is packing, there's absorbable and non-absorbable packing, there are stents, there are drug-eluting stents, and then of course doing irrigation and debridement postoperatively is important. I will just note to everyone, some people think that placing packing is going to be the thing that prevents scarring and changes outcomes, but there is actually good data showing that packing does not change outcomes necessarily. And so this probably has to do with the fact that some packing materials actually have some scarring potential, to increase the scarring potential of the surrounding tissue. And so I would just say choose wisely in your choice. So, if you do end up with synechia, just dividing it in the office is really easy to do if you have all the instrumentation in the office that you have in the operating room to access all these places. When you think about debridement, removing all of the clot and crust and absorbable packing you may have had in there, avoiding aggressive debridement along the skull base or graft site will really allow you to not create a further complication if you had one to begin with. Sometimes debridement can be painful for patients, and that can be limiting, but really take your time and really use all of the appropriate meticulous dissection tools so that you're not really pushing on the patient in a way that you wouldn't necessarily have to. My sort of course is initial debridement at 1 week post-op, and then depending on the type of surgery, it kind of extends out from there, and each person has their own way of doing that. There's many reasons for failure: neosteogenesis, recurrent polyposis, sometimes having that turbinate remnant that you haven't removed completely if you had to remove it for some reason, and having that scar over. These are all reasons for failure. And then considering that surgery is not some magic wand that takes care of all the underlying drive to chronic inflammation in patients, doing topical post-operative medical therapy is just as important as the surgery you did in keeping patients nice and widely open. And then finally, doing a constant and critical review of your own results over time. This requires long-term follow-up of your patients, but it really is not enough to just avoid these big catastrophes, but really trying to craft your skill and improve every single time you operate is what is going to make you the best surgeon and avoid all possible complications as you move forward. So finally, to summarize, develop your own checklists, anticipate what you're going to look at before you do the surgery, identify all the high-risk situations before you're there, go through all of that CT and endoscopic anatomy, and use this precise, bloodless, elegant dissection technique, and follow your own results and be critical of your own outcomes. And that's the end of my part here. If any of you have questions that we don't get to in this discussion part, you can always find me on Instagram or Twitter, and you can ask me questions over there as well. So I'll go ahead and stop sharing so that we can go ahead and discuss.
Thank you very much. So can I ask Bill and Stacy, could you please turn on your microphone? We just have like a flowing conversation. Just as I'm watching the presentation, I just have to ask the panel, what do you think is the most important cause of, in general, the complications that you have seen? Is it lack of judgment? Is it doing surgery for the wrong implication, for the wrong indication? Is it the lack of training? Can you give us your thoughts on this? Dan Bill?
Yes, I think, can you hear me?
Yeah.
Yes.
I think there's no single factor involved. There are several factors, basically starts from training, people not having adequate training, see one, do one kind of a situation, never been to the lab, just saw another surgeon operating and started doing that. For example, the endoscopic septoplasty example that I can give you where you remove the skull base. Then if they have had proper training, then it comes down to indications, knowing what you can do and what you cannot do. Even if the indication is right, the surgeon has to be comfortable with what he can do and should know his own limitations. So I think that's another very important factor. And the third factor is what Zara has already pointed out is doing the surgery, planning the surgery. Exactly, from the CT scan, have a plan in mind and execute that plan exactly as you have planned it before and not cut corners. I am a true believer in a step-by-step technique. That means when you do the surgery, whether you're doing cadaver dissection or whether you're operating, approach everything in a very step-by-step manner. For example, when you remove the uncinate process, the first structure that you will identify will be not the first, but the lamina pepritia. Now, that is a very important landmark which you will follow throughout your dissection as you go posteriorly. So once you have done that, secondly is the maxillary ostium, but the lamina is very important. And the first time you will identify the skull base will be when you remove the ethmoidal bulla and the anterior ethmoidal artery. So once you have the anterior ethmoidal artery and the skull base and the lamina pepritia in view, you can now progress on and go posteriorly. So I always go by a step-by-step manner. My first step is the uncinectomy, remove the uncinate, identify the lamina pepritia, look at the front, do a middle mitral antrostomy, look at the frontal recess, open the frontal recess, remove the bulla, identify the anterior ethmoidal artery, identify the skull base, remove the ethmoidal bulla, and then perforate the basal lamella, identify the superior turbinate, identify the maxillary, the sphenoid ostium, do a posterior ethmoidectomy, and finally do a sphenoidotomy, and then come back again and remove all the bony fragments and come back again anteriorly and look for the frontal recess and complete the dissection in that area. So I think step-by-step technique is very important.
So I have to ask you the same question, but I wanted to look back at the real disasters, not the everyday complications, the real big disasters. What do you think is
big disasters are very uncommon. I mean, I may have showed you some very frightening videos, but they are very rare. They're very rare. This is a combination of, I think, so they have come from all over, from around the region, from US, from Brazil, from all over the world. And but common complications, I think iatrogenic CSF leak just does happen sometimes. And again, it is experience. It reduces with experience. Not being able to control bleeding is another complication that we see because the surgeon has not prep the patient properly or has not, overlooked preparing the patient pre-operatively or intraoperatively with decongestion. So these are some common complications. Bleeding is a common complication, I think. And when visualization is compared, complications happen. A breach of the lamina pepritia happens now on and off, but it's, fortunately, if you recognize it in time, it's not a major complication. It is a major complication when you don't realize it, like the case that I showed you, where you ripped the optic nerve right into the ethmoid sinuses, where you don't realize where you're going, where your trajectory is absolutely wrong. That's when major complications are.
Thank you.
And I would
sometimes, like I said.
Go ahead.
Yes, go ahead, Zara.
No, I was just going to say I agree with everything that Dr. Sethi just said, and I think that the way that he just described, that step-by-step approach, is exactly how I also perform my sinus surgeries. And, the same things that lead to us making these minor little complications are the same things that lead to those major complications. Having too much blood in the field and not recognizing that you don't know where you are. Certainly things like training and not having a plan and not identifying those landmarks as you go through are all going to lead to that same type of complication. When someone breaks through the orbit, like he showed at the very beginning, if you recognize it immediately, if you don't have blood obscuring your view and you can see that little bulge of orbital fat, then you know to stop. But if you have a ton of blood in the field, you're not exactly sure because you didn't identify the lamina when you took down that unsnit and took your bulla over. Those are the things that cause someone to continue with that debrider into the posterior apex of the orbit for 5 minutes or something terrible like that. It's the same exact things that cause these tiny little complications that lead to those major complications. So I really think and the last thing I would say is self-awareness is really one of the things that all of us as surgeons really need to focus on all the time. We have spent many years training and then practicing, and knowing what your own limitations are is the key. Because certainly you can go to a course and see people do, all sorts of amazing, interesting things. But, at a place like any of our 3 centers, we are the people that see the, biggest skull-base cases. We have the most volume. And so we are constantly on a day-to-day basis doing these very large procedures, working in and around the anatomy of the skull base. So we're all very familiar. If you just see one of those a year, you just won't be as familiar. It's just a simple matter of numbers. And so knowing what you are comfortable with and what it's appropriate for you to do, I think is key in avoiding these things.
Stacy, I want to chip in?
Sure. I would echo what everyone has already said. I think one of the most important things is that it's really important to understand that everyone absolutely hates complications. It is soul crushing when something bad happens, whether it's in the operating room or post-operatively for patients. And in that moment, if you are not honest with yourself, you will do your patient a disservice. And so many of the complications that I see, the reason why it is such a horrible disaster is because the CSF leak was ignored, or the bleeding was not was played down, and the patient was sent home without understanding that something had happened. And many of these complications are fixable at the time, and asking your colleagues for help is one of the most important things, and having sort of the strength to have humility when something like this happens, and recognizing that all of us really understand when something like this happens, and it doesn't happen very frequently. And having your colleagues help is something that will help you, but also obviously help your patient. A patient who develops a meningitis a week after sinus surgery because the CSF leak was not recognized, or a patient who develops a carotid pseudoaneurysm because 2 or 3 weeks after the surgery because the carotid injury was not recognized. Those are the patients who really, I think, we had the opportunity to intervene and make it so that they don't actually have such a negative outcome. So I think the more as a community that we support each other, the more that we all talk about the fact that these things do happen, the more that we'll all get better. These complications, I think, are happening much less frequently. They're very severe complications, fortunately. So I think as residency training has improved, as our understanding of surgical anatomy, as our ability to use image guidance and sort of more detailed scans, all of those things have helped significantly. But we can't change the fact that you really have to have excellent surgical technique, and you do have to have you really need to understand your own limitations. And so tackling a really complicated problem, if it's something that you only do once every 3 years, even though that might be a fun case to do, perhaps it's something to do with one of your colleagues that has more experience. I think that's how we avoid these.
I have to tell you that I was looking for a different answer from the panel. Heinz is to say it is because of a lack of any common sense whatsoever. Great lines. So I'm gonna thank you very much, all of you. It's a terrific talk and a terrific discussion. I'm gonna hand it over to Pablo for a closure. Thank you.
Thank you all very much. This was an outstanding session. A special thanks to Dr. Terabici and Dr. Herman for moderating this outstanding program, and our deep appreciation to our faculty, Dr. Patel, Dr. Gray, and Dr. Sethi. I was gonna show you a couple of things that are coming up, and I'd like for you to save the date. We like to invite all of you to our 125-year anniversary of the American Academy of Otolaryngology. We're going to have an outstanding, hopefully in-person meeting in Los Angeles, October 3rd to the 6th of 2021. So we look forward to hopefully seeing you in person there. And we also have the privilege, Academy will host the Pan American Congress, which will take place in Orlando, Florida, June 25th through the 27th of 2022. Save the day. We look forward to seeing you in person. And we will continue with this virtual global ground rounds. Our next one is going to be June 19th, and it's going to be on sleep surgery. August 21st will be an update on endoscopic ear surgery. And November 20th, we'll have a thyroid cancer, new treatment paradigms, and technologies in 2021. Thank you all very much for attending. We love this weaving of the global community, and on behalf of the Academy's Global Affairs, thank you so very much. We hope to see you soon. So long.